Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome to Airway Answers. We have Dr. David McIntosh, ear, nose, and throat doctor, on again. You're a repeat guest, Dr. McIntosh. I think that's like the fifth, sixth, seventh.
It's whatever number it is, and you can't have too much of an opportunity to share the knowledge. So I appreciate the opportunity.
I love that. That's amazing. We did a 4 or 5 part series, and then I had you on with Dr. Simmons, with Bill Harrell, where we did group interviews, and your desire and internal motivation to spread this message is so important, and we're so grateful. Right before we just started recording, I was apologizing because it is Saturday, 6:30 a.m. your time, and you are voluntarily doing this to spread the information, and you already had a meeting before this one. You're crazy. But no, this is honestly, it's the passion to get this information out there that is just this internal need that we have to spread this information. And again, I thank you for doing this.
No, it's my pleasure. It really is.
And I see you on social media groups helping parents, just responding as best as you can. And I really hope everybody who's reading your insight is appreciating the time you're dedicating to doing that and providing whatever thoughts you can share with people, because you're busy, you're a doctor, you're a practicing physician, you're doing surgeries, seeing patients, and just doing everything to help. You've written tons of books. And today, actually, we're going to talk about a recent book you just published called Female 40, Fatigued and Forgotten. So you wrote that book for me, about me. Just kidding. But it could be.
Yeah. It was N equals 1. I'm surprised I sold more than one of them. Because
Totally.
it was only you.
It's so funny. Thank you. I appreciate it. No, really, though, this is going to hit a lot of women really personally in this content of what your book is about. And today, what we're going to be talking about is a group of patients who are often told their labs are normal, their sleep study's fine, their symptoms are just stress, hormones, or, oh, you're just getting older. When in reality, their airway and breathing during sleep are being completely overlooked. As I remember Dr. Stanley Liu, ENT in the United States, once said, females with upper airway resistance syndrome are the most overlooked population.
They really are.
It's true. And women with sleep disordered breathing, including upper airway resistance syndrome, are frequently missed because they don't fit the classic sleep apnea picture. They may not snore loudly. They may not have oxygen drops, if any oxygen drops at all, but they're exhausted, foggy, waking up with brain fog, anxious, and struggling, and sometimes for decades. This could be going on for a lifetime since childhood and completely unrecognized. So joining me today, we have Dr. David McIntosh, ENT, sleep specialist, and I like to say airway ENT because, as you've already talked about in prior podcasts with me, with other people, that not all ENTs are airway educated. Some have different areas of focus, like cancer treatment or different types of things. So you have that specialized airway insight. And you wrote the book, Female 40, Fatigued and Forgotten. And in our conversation today, we're going to unpack why so many women fall through the cracks, what red flags clinicians and patients should be looking for, and how we can do better at identifying and treating airway-related sleep disorders in women. So this episode is, I feel, it's going to be a must listen to for professionals like dentists, orthodontists, myofunctional therapists, hygienists, speech pathologists, and also patients. So anybody who wants to understand why, quote unquote, normal doesn't always mean healthy, especially when it comes to breathing and sleep. So let's talk about this book. When did you publish this book? When did this book come out, Female 40, Fatigued and Forgotten?
Yeah, so this one's come out in the past 6-12 months. I lose track of timestamps with everything else that I do. But it was really, again, you sort of reflected on, my lurking around the place. I started to see a trend emerging in the different circles that I walk in where people were starting finally to talk about women but talking about it in a way that they said, look, we just don't understand this. We don't get it. Like, these women are turning up, they've got the symptoms of the breathing disorders, but their numbers on paper look fine. What's going on? Is it hormonal? Is it they're stressed? Is it the change now that women are moved on from their role of just looking after the household, and now they have a job, and then they're trying to balance a career, and then as they get into their 40s, they're starting to get into higher echelons of what they're doing, but the kids have got older and they're just burning the candle at both ends and they're just exhausted. And that's actually how it sort of gets fobbed off as. And the problem is there's a whole range of dynamics that are playing into this conversation. And one of them is the history of this disease in the first place. As in very simple terms, as I often explain to people in my talks and my lectures and my other books, this whole sleep apnea, this is what people focus on, all right, as a starting point. We focus on sleep apnea. Why? Because that was the thing that we found first. And where did we find it? We found it in data of insurance companies. Now, not health insurance companies, motor vehicle insurers. They picked up on it. And the thing that they picked up on was men having a disproportionate number of accidents driving cars, driving trucks in particular as well, just when they started to filter out their data. And when they started to sort of dig into it, what they sort of tripped over was that one of the commonalities is these men had described moments where they literally just fell asleep behind the wheel. They just had what we now call a micro sleep. And they just nodded off, just that little jolt. And then backtrack the fact that they were snoring. And then they started to investigate the snoring and started to find that they had obstructive sleep apnea on the measurement tests. And they fitted or developed an avatar. And that avatar became the fact that not only were they male, but they were overweight. And that is our starting point of the journey of discovery of obstructive sleep apnea. And it's why in the evolution of time, when we look at children, why it's all upside down, because children are not small adults. And the measurements and the numbers and everything we've got about children are totally made up. They're not scientifically based. But we have some numbers for men. And then I can remember living through this. I'm showing my age, but I can remember living through this where I would see patients 20 years ago that were thin and petite and presenting, and this is men and women back in the day, presenting with all the hallmarks of what we were focusing on, them being obstructive sleep apnea. But they were thin. So we'd look at them and go, oh, you can't have that. We were totally dismissive of anyone that was thin having any form of airway obstruction. Now, obviously we've progressed and evolved, but the mere idea that their skeletal deficiencies could be enough to cause an airway problem didn't fit. We just thought you're overweight, you've got a lot of, let's call it for what it is, fat around the neck, in around the throat, blocking your airway, and that's the problem. So that was sort of the evolution, and we started to get a better understanding and awareness. But again, we still really tunnel visioned on men. And then finally, we started to see the evolution and permutation into the system of this thing that you've mentioned, which is upper airways resistance syndrome. Now, this is a really important point in terms of lines in the sand, because when we look at the proper terminology, in my mind, that being sleep disordered breathing, that is a spectrum. And the spectrum at the end stage of the disease is obstructive sleep apnea. There's a whole lot of steps before you get to there, but they're all steps in a spiral that goes downwards, so forth. And that initially can be mouth breathing or snoring. That's your kickoff point. And that's because there's some form of airway restriction. The mouth breathing, your nose is blocked. Again, I had it yesterday. She comes in, she goes, "Oh, I'm just exhausted. I do a lot of public speaking and I'm here because I'm losing my voice." I was like, "Okay, well, look, you're using your voice a lot and so forth, but is there anything contributing to it?" As you know, being a speech pathologist, we sort of go, "All right, well, you're getting reflux." "No, I don't get reflux." You go, "Okay. Do you have problems with your nose?" "No, my nose is fine." We go, "Okay." And then he goes, "Oh, but I am a mouth breather." It's like, right. We have a look at the nose. The septum's deviated, the turbinates are enlarged. Inside, further down, the throat is dry. And again, so she's getting problems with her voice because over the passage of time from the mouth breathing, her throat is drying out. The lubrication that you need for the voice box and the larynx to glide and slide is diminishing. And then because of the work that she does, she's losing the voice because there's a strain on her voice more so than someone else's. And this was the end point of the conversation. I said, "So look, I know you came in with a voice problem. That's manifesting because you've actually got a nose problem. And it's a nose problem that you're totally oblivious to because you've had this for so long that this is just your normal." And you said, "I'm a mouth breather," so dismissively as it being normalized that you don't recognize that's actually a problem. And this exhaustion that you've got, you're not breathing properly, you're not sleeping properly. And we have, unfortunately, this thing called birthdays, which are to be celebrated, but every birthday that comes along also is a reflection that our resilience has dropped a margin as well. We don't get away with what we used to get away with when we were in our 20s, unfortunately. As much as we might want to reminisce, we just don't. And that's in sort of the things that we can relate to. But your body internally is very much the same. And this thing eventually chased her down. But in the process of doing so, nobody had made the connection to any of her other health problems. And it was only fortuitously that she started losing her voice that we could actually start working out what the moving pieces were in terms of her breathing and her sleep and her fatigue. So her agenda of voice problems got flipped. I heard her talking at the reception desk. She's going, "I came in for a voice problem and now I've just had a whole lot of my other life problems solved."
Okay, I was going to say, how did she react to that? So
Yeah,
sometimes it's overwhelming for patients when you open that can of worms, that domino effect of you were here for one
yeah,
thing, but really that's a symptom of many other things. But she
yeah.
felt like this was not overwhelming. You're solving some other really important things for her.
The primary thing that people in general come in when they've got a sore throat and voice in particular that's playing up is they're petrified they've got throat cancer. Absolutely petrified. So as soon as they know they don't have that, the sense of relief that comes from that alone, but the fact that I could put extra layers onto that was just really effectively the icing on the cake in terms of the mindset of the initial pre-consult anxiety, worry, concern, and also occupation. Like I'm losing my voice. Like this is how I make my living. Am I going to have to look at another career? There's all these internal questions people have, and they come in and we have a look and then the conversation pivots most of the time. It's always a joy when the conversation does pivot. It is a little bit heartbreaking, but you got to be realistic as to what you can find at times. But the conversation pivots. For some people, that's it. That is the end of it. They just need to look at vocal hygiene and get some professional coaching on using their voice, and that's fine. But in these situations where you sort of go, well, hang on, I can actually help you a lot more than what you ever budgeted for. That situation, yeah. But you're right. And I find this is more when the parents bring in a child. Parents in a state of conflict, they know there's something wrong with their child. They know they want their child better, and they dread the fact that it's going to take surgery to achieve it. Alternatively, they don't think there's a problem with their child, but they've been directed to seek an opinion because someone does think there's a problem with their child. And the parents go, "Well, my child's fine. Every child snores. And what 3-year-old isn't tired and cranky," and so forth. But again, this is just a sad sign of how pathology has been normalized. So in terms of the pushback, if that's the right term, or the reluctance might be the better term as to those conversations, most of it is the parent that is either absolutely dreading the idea of surgery or has no good understanding that their child is actually in a lot more trouble than what they've come to appreciate. And neither of those are criticisms. Nobody wants to sign up for surgery thinking that's the be all and end all of everything. But in children, it often is. And this is where people, I understand, are seeking and chasing alternatives and stuff. But at the end of the day, most children with sleep disordered breathing need surgery. Most overweight people need weight loss. Most women, when it comes to the causes in women, mostly in my experience, it comes down to, I'll call it 2.5 things, because it's sort of 2 or 3, but number 2 and number 3 overlap a bit in some respects. Number 1 is their nose doesn't work properly. That it just doesn't work properly. And that can be something that, again, relates to some pre-existing problems that weren't too bad. But then as they start to get into perimenopause, the hormone changes how the nose works, and it changes it for the worse.
Okay, can you talk a little bit about what happens with hormonal changes and what
Yeah,
happens in the
for
nose?
sure. For sure. Women will notice this too in pregnancy. If we go circle back to hormones in general, the way that the nose works in terms of congestion and decongestion and blood flow partly relates to estrogen and progesterone, to the sort of 2 of many very important generalized female hormones. And those hormones change during pregnancy, and they change because of menopause. And the net effect of the imbalance between those things is that the nose starts to congest up. Now, if you have a pre-existing problem, so if you have hay fever, but it's in inverted commas not that bad, I can manage it, it's not that bad, but then the hormonal changes add an extra layer to it and amplify it, not because it makes the allergies worse, it just makes the congestion worse. In that person's mind, they present saying my allergies are getting worse, because that makes sense in terms of their relationship to their nose getting blocked, and they're noticing that they're getting more symptoms. It's been hay fever their whole life, so that, oh, my hay fever's got worse. Well, actually, it possibly hasn't. It's just you've got 2 problems now, not 1, and there's ways around all of this. Or they have a pre-existing septal deviation, again, in inverted commas, not that bad. When you have a septal deviation, there's these structures within the nasal passages called turbinates. The turbinates are the things that congest and decongest. One of the causes of abnormal turbinate size is a deviated septum. So this is why historically, when we would fix deviated septums by only doing that alone, people still felt they couldn't breathe properly afterwards. It wasn't until that we corrected the turbinate size at the same time that we started achieving much better results. And look, sometimes we get lucky. Sometimes people come in and it's just a septal deviation and they don't have the other turbinate dysfunction, but often it's a combination.
Can I chime in one thing about this? Because what you're
Yeah,
saying is, and what we're focusing on, women, midlife, hormonal changes can
yeah,
trigger, you said, can trigger congestion, which
yeah,
might not necessarily be a problem, but when there's already a pre-existing dysfunction or abnormality, craniofacial
yeah,
abnormality, allergies, now this can put someone over the edge, like the straw that
yeah,
broke the camel's back, right? So this
absolutely.
is
Yeah,
just one more vouch for early intervention and addressing these issues in early childhood. Even if a child might not be symptomatic, we want to
yeah,
set that person up for a lifetime of better health opportunities, because as we age, things get worse, right? So
yeah,
if
yeah,
perhaps there was a palatal expansion or this deviated septum was addressed when that person was younger, the hormonal changes might not really trigger a problem when they're older. So it just puts me in
yeah,
thinking that. Another thing I
yeah,
wanted to say also about that is, so people understand, upper airway resistance syndrome, I've heard people term it as the thin fit female syndrome. Also, men can have UARS, but it's that population of people that don't fit, like you said, that classic stereotype
yeah,
of having sleep apnea, old, overweight man. And what I learned was that upper airway resistance syndrome was actually first identified in children. I believe it was 1984. Dr. Christian Guilleminault
Yep.
identified these sleep patterns in children. And then later it was determined adults can have this also. So
Yeah.
when I see patients, those females, middle age, who have signs of UARS, it's very similar to the issues I believe we see in children who aren't
Yeah.
obese, but that
Yeah.
similar profile.
Yeah. And again, if we just circle back to the children for a moment, and Christian Guilleminault, these names mean a lot to you and me, Nicole, but for those that might be tripping over this for the first time, we have what's called a sleep study. And on that sleep study, we measure a whole range of parameters. And the ones that people zero in and focus on is, from a breathing point of view, is what's called an apnea, which is where you stop breathing completely, and a hypopnea, where you still manage to shift some air through the system, but it's markedly reduced with respect to how much you should have got compared to your normal breath. And that's called a hypopnea. Okay, so near means breath, P-N-O-E-A, it means breath, near, and A in front of it means without, and hypo means less than. So we have apnea and hypopnea. That's the sort of meanings of the words when we break it down. And that's what we predominantly focus on. And again, we did that in men that were overweight. And then we started to notice the children were having sleep apnea. And again, they weren't fronting up, obviously, having car accidents. They were fronting up having problems at school. And we had this thing called a sleep study. And so we thought, oh, well, we need to measure these children as well. And we used adult numbers. We used male overweight numbers for adults for children. And there's all these children, and they were perfectly fine according to the numbers on paper. But clearly they weren't fine. Like, we could see these kids were not fine. And this is why treat by numbers is such a ridiculous concept, because at the end of the day, one thing I'm known for is a mountain of analogies, okay? And some of my analogies are, quite frankly, are pretty blunt and to the point, just to raise the point. So one thing I can say is, let's go treat by numbers. So one thing I can do is that I can go to a machine and I can punch the little punching bag, and it will measure how hard I can hit, okay? So that's my measurement, all right? That says how hard I can hit. Now, if I was to then go and we line up a UFC, fully trained UFC fighter, and punch them as hard as I can, they probably wouldn't even blink. Okay. And then if I was to go and find someone else that's outside of that realm and do the same thing, they'd probably be pretty damn sore. Now, nothing that I have done has changed. Okay. But the impact on that individual is chalk and cheese. And that's why Christian Guilleminault started to realize things were going sideways in terms of how clinical medicine was applying the things that he was doing in research. Because clinical medicine was doing here's the measurement. We're going to measure just how hard this person got hit and make a decision whether it hurt or not. And the equivalent is that they started off measuring it in professional fighters and then said, well, professional fighters can tolerate this much punching, so everyone else is the same. And anyone that looks at that analogy goes, well, that actually is a whole load of hogwash. Nobody wants to be hit by a professional fighter, not on a month of Sundays. This is what happens to these airway things, and it hits children harder. It hits women harder.
That's what I was going to say. So women
Yeah.
can be way more symptomatic with
Yeah.
a lighter hit on the,
Correct.
So,
Correct.
okay, can you just summarize upper airway resistance syndrome? Because that's what we're talking about a lot with the middle-aged females, is that the oxygen is not really dropping, right?
No.
What's happening?
Yeah, so what I'll do is I'll circle back to that, but I'll finish off on things. So we talked about women and noses, and you sort of crept in there too about the skeletal form. And that's where my 2/3 average to 2.5 comes into the mix, because the two anatomical regions that women fall down predominantly is their nose and their lower airway. So that lower airway is around their neck level. And what happens in that territory is that the muscles around the throat that keep it open start to lose their strength, and they start to get pharyngeal collapse. So the throat in medical terms is called the pharynx. Okay, so if you've heard of the larynx, that's the voice box. The part of the throat above and around that is called the pharynx. So that's the pharynx is where I'm sort of just in and around my neck there and there at the moment. And that collapses. And that collapses partly because having a blocked nose and mouth breathing leads to the loss of muscle strength. And the other part is skeletal deficiencies. And especially when they've had a nose problem and they've been a mouth breather and they've got these skeletal deficiencies. So these skeletal deficiencies relate to the jaws. So their top jaw is narrow, their bottom jaw is back. That steals real estate from their pharynx. It also makes their pharynx unstable. So in the majority of women, what I see that does them the world of good is getting their nose working properly and getting a mandibular advancement splint and doing myofunctional therapy to build up that muscle tone again to get them back on track. And it's game changing. So, like I said, to circle back and round and through circles again.
I gotta do one more circle. You said the hormonal changes can cause that inflammation in the nose. So two things I want to ask you. I'll ask them both at the same time, and then it's going to be a lot, so we'll go back to one.
Yeah, but this is the nature of the condition. This is why it's so important to do it this way, Nicole, because this interweaves itself. This conversation actually reflects the disease. And in saying that, it also then highlights why you won't get simple answers and why you will absolutely not be able to solve your problem asking people on social media for specifics. It's all generic until you see someone that knows what they're talking about.
And that person has to see the patient also. Detailed history, oral exam. There's so much that's involved because these issues we know are multifactorial. So what helps one person doesn't help another, and we need to know the big picture. But we talked about hormonal changes causing inflammation in the nose. So can you tell me what other things hormonal changes may cause in the middle-aged female? So that's number one. So that perimenopausal and menopausal age, you said the hormonal changes, progesterone, estrogen. What else is happening beyond the inflammation? And the second thing is my age. So many people are now talking about hormone replacement therapy, the patch. Does that help with any of these things? So start out with the hormonal changes. What else that could cause?
Yeah, well, look, I mean, it affects your muscle tone as well. So there's that. It can start to change your fat distribution. So you got that. And then you go into these next spirals where because you're feeling tired, you start to put a little bit of weight on. And that little bit of weight is fuel on the fire for all of this as well. So you have that in the mix that's interweaving with it.
Jumping in again, because whenever we talk about weight, putting on weight, in this conversation, we're talking about those females who might just be borderline like straw that breaks the camel's back, a little weight gain, even if the female's not obese or overweight, could cause a problem. And another thing I want people to know is the tongue is a muscle. When you gain weight, the tongue gets larger, the tongue gets fatter, and that has been shown to increase the severity of sleep disordered breathing issues, which is very interesting. I don't think patients might necessarily think about that. Okay.
No, the other thing the other layer on the cake with that one is that snoring makes the tongue get bigger too. With the snoring and the vibration, it makes the tongue swell up. So if you ever wanted to create the perfect disease that basically feeds itself and makes it worse, this is it, front and center. One little thing that goes wrong in one direction and this domino effect that accumulates and then keeps spiraling. You start off with a nose that doesn't work properly. You progress to mouth breathing. You then progress to underdeveloped jaws. You then progress to poor muscle tone. You then progress to putting on a bit of weight because you're tired. You progress to snoring, which causes the tongue to swell up. Like, it just keeps going.
And then the other impacts of when you're not breathing well and sleeping well, you might wake with headaches. So now you're not feeling good. You might get anxiety, depression. So now you can't function. You can't make it to work, or you can't get yourself motivated to go exercise. or you might get put on medication, SSRIs for depression or other issues that have other side effects and symptoms. So you're right in calling this a domino, a spiral effect.
And we can jump outside of that box, and this whole sleep disordered breathing thing, it mucks up the gut. And it mucks up the gut in such a way that your microbiome changes, and it changes in such a way that your metabolism changes, that leads to gaining weight. And that microbiome change also then seems to have some sort of communicative effect with the brain that changes your food seeking behaviors. And you tend to go for high energy, low nutritional value foods, which is just weight gain. Like it keeps going, and look at, we're going left, right, and backwards all over the place. But I think this is a good thing for people to understand about just bringing it back to such an extraordinarily simple, basic concept. You need to be able to breathe properly, and that front and center involves having a nose that works properly. Front and center. In terms of foundations, that's so important. And look, I know we talked about menopause and perimenopause, but I've mentioned pregnancy as well. We know that through the course of pregnancy, you're going to put on weight. And we know that there is now this thing that is basically pregnancy-related obstructive sleep apnea. So you'd never had breathing or sleep problems before, but putting on the weight that comes with being pregnant, plus having the baby in your womb, and that it puts restrictions on your diaphragm movement, which is restricting your breathing, and the congestion that you can get from the estrogen and progesterone changes and everything that goes with being pregnant. We now have people that we both know, Candy and Brad Sparks, who run the Childhood Airway Health Foundation, who have now branched into looking after pregnant women and looking at assessing women that are pregnant for airway obstruction and providing CPAP during that timeline, with the scientific benefit showing it's good for the mum and it's good for the baby. And medicine's got a lot to catch up. We finally caught up to the fact that these women having obstructive sleep apnea in pregnancy are also then at risk of having obstructive sleep apnea later on in life. It's kind of like a warning sign. But again, it just circles back to looking at everything and anything that we can to do that. And then again, to circle back, and I've lost how many circles we've got now, Nicole, but
They're all overlapping.
They're all over it.
Circle on a circle.
You asked about hormone replacement therapy.
Good that you remembered. I have it in my notes because whenever I go off topic and back and forth, we never remember the initial question. So good for you. Hormone replacement therapy. There you go.
Yeah. And again, I don't know if I'm showing my age, but I can share my life journey. So I can remember being at university. So I was at university in the early 90s. And I can remember again, I don't know how I fluked this. I just had the right people in the right place at the right time. Because one of our lecturers, as part of what we cover, as part of our general medical training, is we cover obstetrics, gynecology. And the person that was taking us for it was actually one of the world leaders in hormone replacement therapy. So from that point of view, we had their contribution to things. And they were saying back in the 90s, just how beneficial this stuff really was because of the changes that come, how women's health changes. So women, for example, don't get heart disease in the mainstay when they still have their cycles going. But as soon as they have gone through and they're menopausal, their risk for having a heart attack rapidly escalates and nearly matches that of men. And again, that's just the protective effect of the hormones and so forth, and how treating that mitigated that risk enormously. Now, the big concern has always been about giving hormones and the effect on hormone-dependent cancers. And the big one's been breast cancer, because roughly speaking, 1 in 14 women, and these are the numbers that I'm familiar with, and I think they're still the case, 1 in 14 women are going to get breast cancer. So if you look at that from a sort of simple point of view, say you've got a class of children and they've got 30 children in that school class, which means you've got 30 mums. And that mum, there's a mums group. 2 of those women are going to get breast cancer. That's the statistic. And breast cancer is, in many, not all, is hormone dependent. Part of what those cancers actually are supported by in their growth is having the hormones in the first place. That's why hormone therapy evolved in the management of breast cancer. So the flip side to that is, well, if we're giving these women hormones, what's going to happen to the cancers. And there was a whole lot of research that looked at this and focused on it. It was called the Women's Health Collective. And it has to be historically one of the biggest disservices that's ever been inflicted upon women, because the outcome of what that said back in the day was this therapy is really risky for women. That's all been revised and looked at, because you've got to look at the big picture. When we do these things, there's swings and roundabouts. You're pulling levers, trading things off. So any potential increase with breast cancer or hormone-dependent cancers is way, way, way offset by magnitudes of all the other benefits. Less heart disease, less vascular disease, less strokes, even bone density. When you go through menopause, for women, their bone density starts to really diminish. A lot of people don't realize these things, but if you fall over and fracture your hip, and it's mostly women that this happens to, all right? So if you're like in your 60s, 70s, 80s, if you fall over and fracture your hip, 50% of the people that have done so within the next 12 months have passed away. Not because they broke their hip, but by virtue of breaking their hip, they become immobile for a while. They're at risk of getting deep vein thrombosis. They're at risk of basically having to go through surgeries. They have to have anesthetics. They're at risk of getting pneumonias. There's a whole lot of things that happen where, again, we just don't have that resilience in our 60s, 70s, 80s that we have in our 20s. You break your leg when you're 20, you get over it and you get on with it. You do that when you break your hip. 50%, this number was true when I was at university, it's still the number today. 50%, you will be dead within 12 months because of other diseases that chase you down. And it was just having the broken hip was enough to set that spiral on its course. And that's because of low bone density. And that is exacerbated by the hormone changes. So you've got me here sitting as an ear, nose and throat doc talking about things that clearly don't belong in my neck of the woods. But I think it's important to understand all these things.
Yeah, it makes me wonder, does hormone replacement therapy have positive impacts on the airway for women?
Yeah.
Could it prevent that spiral to maybe going from UARS to OSA? So from going the airway resistance syndrome to sleep apnea, or at least maintaining?
Yeah. Well, this is the problem, is nobody has focused on this problem properly. Hence the reason I can write a book about it and bring a whole lot to light. But these are the next steps of the journey. Now, we don't use it that much, but we can use estrogen drops. You can get estrogen drops made out compound pharmacy, and you've got to look at the dosages and so forth. This is all just generic advice. This is not specific to individuals, where we can help the nasal symptoms. But again, if they've got underlying allergies, they've got underlying septal deviation, this is a surgery thing again. You can call me biased and so forth because this is what I do, but this is what I do. I speak to this clearly knowing a lot of things and options and alternatives. But at the end of the day, if you have a structural problem, if you have a deviated septum, there is no amount of anything else you want to substitute that's going to work around that. I don't care if you talk about breathing exercises or medications or whatever. It's not going to change the fact that you've got a structural problem that needs a physical solution. So look, I think you're certainly right. And the thing that, again, throw more circles is the fact that with women, we focused on apneas, we focused on hypopneas. There's something else that we can measure, and that's called arousals. And this is, again, going to my sort of analogies and so forth of sorts as to things in terms of what does it take for someone to basically get woken up because they're choking at night. Okay, this is all about airway obstruction. This is choking in simple terms. What is it? How much choking do you need before you'll actually wake up at night? And it turns out for children, not much at all. And the reason for that is that sleep is extraordinarily important for a whole lot of things, of which, to name but one, is the brain growth and development. And the time of our lives where that is front and center more than anything else is childhood. So children need sleep far more than adults do, far more. So anything that interferes with sleep, and which airway obstruction is the case, makes their situation a lot more fragile, because that brain, it does not want to be interrupted or disturbed at all. Okay. And the
And they're
breathing
also
problems do
also,
just
I
that.
think the children have a lower arousal threshold.
Well,
So,
that's what I'm coming to. Exactly right.
okay.
Yeah. Yeah. So the brain will not tolerate any disturbance at all. So anything that causes even a minor disturbance, they get this arousal. They get this
So a
measured
little
change.
bit of airflow resistance,
Yep.
right? A little bit
Yep.
of
It's
increased
just a
effort to
bit.
be working a little
It's
harder.
yep.
That
Yep.
brain just,
Yep.
it's like that your nervous
Yep.
system is
Yep.
on fire, right?
Yeah.
That autonomic nervous
Yeah.
system is super
Yep.
reactive in children
Yeah.
and
Yep.
women who are that non-apneic type.
And that's exactly what we've found, is that the threshold next in the queue in terms of going from lowest to highest is women. So what that means is just a little bit of a breathing problem the brain doesn't like. Now, look, I don't know if this is partly a trick of nature, because part of the nurturing role of women obviously is breastfeeding, and the baby will let you know it's hungry at 2 in the morning, and then at 3:30 in the morning, and then keep going. So in some respects, and this is just pure speculation, have women been programmed to wake up easier because of that biological necessity? And has that inadvertently then set them up for failure when it comes to having a breathing problem? I don't know if that holds water or not, but as a concept, it kind of makes sense.
It's an
Because
interesting thought. It's kind of funny because my husband used to joke that I'm the neighborhood watch, because when we go to sleep, I could hear any sound on the street. I was like, "What's that? What's that?" Go look out the window because of that
yeah,
just low arousal threshold or not getting
yeah,
into very deep sleep. And
yeah,
I was one of those females that got missed on the sleep study. So when we talked about sleep studies being geared towards apneas, that pause in breathing for 10 seconds or more, that apneic criteria, oxygen
yeah,
drops a certain amount for
yeah,
10 seconds or more, 5 times or more an hour. That's when we start counting those events. And
yeah,
women can easily get missed on sleep studies if they're using that same criteria. Can you
yeah.
talk about that? Because I think we're going to have listeners, women who have had sleep studies, maybe take home sleep studies.
Mm,
Maybe they've gone into a lab and the results said no sleep apnea, or it's just mild, or mild snoring, or it's
yeah.
positional, and they say, oh, I'm fine. What's getting missed here and why?
What's getting missed is the fact that no one's listening to their symptoms. Okay. This is again going to a treat by numbers. Okay. So again, this is the problem with the system. So yes, we need to measure the apneas. Yes, we need to measure the hypopneas. Why? Because that's what everyone tells us we're supposed to do. Is it overly helpful and representative? Funnily enough, it's not. But this is the concept that we've got. But for women, we also need to measure. I mean, for everybody, we need to measure these arousals, and we need to move on from talking about the AHI, which stands for the apnea hypopnea index. So just to explain for people, we do a sleep study, we measure how long you fall asleep for, we count up your apneas, we count up your hypopneas, we add those two numbers together, and then we divide it by the amount of time that you're asleep, and we develop basically a number per hour. So we have a certain number per hour, and we've created different thresholds as to what's normal versus mild, moderate, and severe. And we can circle back to that too. And that's all based initially on overweight men. And then we realized those numbers were too high for children. So we just created a new number for children. All these numbers are made up. People don't realize this. All of these numbers are made up numbers. They're not actual real numbers. Like if you go get a blood test and they measure your calcium or your sodium, they're real numbers, okay, based on physiological norms. And then we have a range that tells you if you're too high or too low, then you're a pathological range. And that's based on known disease states with studied populations and understandings of population averages. An AHI of 5 was made up. It's a made up number. And you look at the measurements. What's the next number in the queue? 10. What's the next number? 15. These are nice round human numbers which have absolutely no underlying physiological or pathological basis for using them.
What's important to note is a person with severe sleep apnea can be less symptomatic than a person who shows up as mild sleep apnea. So perhaps that
Yeah.
thin fit female with a UARS that shows up as mild sleep apnea may be way more symptomatic than an overweight male or individual who is showing up with moderate to severe sleep apnea. Each body handles the stress, the physiologic stress, differently. And what we're also missing is in those numbers, we're missing important information. Respiratory effort. Can you talk about that? So on the sleep study, that effort to breathe, what's going on there?
Yeah, so exactly. So if we think about, if you have a blockage, all right, and we're measuring what's flowing through something that's blocked, if all we're doing is measuring how much goes through, but we're not measuring how hard we're working to get it through, then we're just getting a representation of what's going through. So if we measure a normal caliber tube and we can push 1 litre through that tube, we'll measure 1 litre. If we narrow that tube and we put extra pressure and effort into forcing it through, we can measure 1 litre as well. So the measurement of flow was exactly the same, but there was nothing that told us how hard did we have to work to get that to flow through in the first place. And this is where people with obstruction, part of the compensation is to breathe harder. And as a consequence of breathing harder, it looks like you took a normal breath. You didn't have a reduction in airflow because we measured the airflow and it was the same. We didn't measure how hard you breathed. But the other thing then, like I was saying, is we're not, depending on what study you get, you may not be measuring these arousals. The arousal is a brain measurement. It's not a breathing measurement. It's a brain measurement. We're looking
You need
at brain
EEG sensors, right? So a home sleep study would not pick up on this problem because you need to see with that increased effort to breathe, is the brain arousing?
Yeah. So we have this situation where the brain is realizing that there's a breathing problem, and to work around it, it in inverted commas wakes you up. Okay. It gets out of its pattern and it wakes you up a bit. And in the process of waking up, so part of what happens when we sleep at night is the muscle tone around the throat drops a bit. And again, if you're vulnerable, that causes problems. So your brain wakes you up a bit, you take a bit more of an extra breath, you have a bit more better muscle tone, and you get a normal breath. But you don't recognize that you've woken up through the night. But you could do this multiple times throughout the night, and that has fragmented your sleep. And the consequence of that is you just wake up exhausted. And you're like, I can't believe this. I've been asleep for 10 hours solid, and I just feel terrible. And this is probably the next sort of thing about all of this. I don't know what your experience, Nicole, is, but I know that in the mainstay, when I have a patient that is male turning up and there is a female that comes in with them, this is just a pattern thing, this is just what I see. Most of the time that guy is there because he snores really badly, and she is there to make sure that he gets it sorted because she's done. She's over it. And when it flips the other way, the woman comes in and just drags the partner along. The partner doesn't really know what's going on. The guy doesn't really know what's going on. And as much as we as men get blamed for not paying attention, and probably rightly so, there's actually another underlying reason here. Men will sleep through their female partners snoring because our arousal threshold is so much higher. It takes a lot more to wake us up. So often the conversation is, oh yeah, we both snore, but the woman, the snoring is really annoyed by his snoring, but the guy's not worried by hers. And she could be snoring far worse, but it doesn't reach into that arousal threshold situation. And as a result, this is the other reason that women get underrepresented, is because their partners are sleeping through the signs that there's a problem in the first place. The partners are not their witnesses to it all.
Mhm. And also, I want to tell my story of what happened to me. And I've said it on
Yep.
others. So I don't know if you've heard this, it's repetitive. But I think if someone's tuning into this episode, specifically a female who's having this frustration because they're not getting the correct diagnosis or they're concerned, when I realized I must be symptomatic, I want people to know that you don't have to snore to have abnormal breathing, like upper airway resistance syndrome. I typically did not snore. And you don't have to mouth breathe. I would sleep with my mouth closed. You don't have to be a restless sleeper. I would go to sleep, and I'm talking about past history before I sought some treatments for this, but I would literally just lay on my back, fall asleep within maybe a half of a second, which was a sign of being overly tired. I didn't know. I thought it was a skill. I lay down, done. I could fall asleep right away. Don't move at all. From what I know, wake up the next morning. But waking up kind of grumpy, this like brain fog, which I didn't realize I had brain fog until it went away. Waking up moody, stomach ache, which was actually reflux, which I didn't realize, like this pit of my stomach pain. And when I stood up and walked around, it would go away. Severe
Yep.
depression. I had nothing to be depressed about, but I'd wake up in
Yep.
the morning so depressed that I'd just have to go running. I'm a runner. And that would just kind of clear my mind and start feeling better. Lots of signs and symptoms. And I didn't
Mm.
know that could be related to my sleep quality and breathing
Yep.
until I started learning about this. So I
Yeah.
went and got a sleep study, your typical sleep study, and the results came back. And I actually paid cash because I knew about respiratory effort related arousals. And I called all of the labs in my area and I said, do you measure respiratory effort related arousals when the brain is arousing due to increased effort to breathe? And this place said, yeah, we do that. So I paid $900 cash for this sleep study at a network with insurance. And the results came back. My AHI was 0. My spontaneous arousal, quote unquote, was like 65 in like 5 hours of sleep. So they
Yep.
said I was just waking up spontaneously, no reason, but I was
All right.
waking up every, couple minutes. My brain was,
Mm.
my body wasn't waking
Yep.
up. I didn't know. I'm sleeping. I'm
Yep.
not turning. I'm not
Yep.
literally physically waking up and talking to
Yep.
someone. I didn't know. But
Yep.
they could see on the EEG, my brain's arousing 65 times in just a few hours of sleep. And they
Yep.
said, you need cognitive behavioral therapy for insomnia. That was the result. And I said, I don't have insomnia. I could fall asleep in a split. I could fall asleep I go to movies so I could take a good nap. Like
Yep.
I could sleep
Yeah.
anywhere. So that was
Yeah.
weird. So, but I was actually relieved because I thought I don't have sleep apnea. This is so great. This does not
Mm.
explain my problems. I don't have
Yeah.
sleep apnea until I learned more about upper airway resistance syndrome.
Yeah.
And I flew to a lab in Texas. We know Dr. Simmons, who's a sleep physician, who does something called pharyngeal esophageal manometry on his sleep studies. So he has you put a catheter that goes
Yeah.
down your nose, you kind of swallow it. It measures intrathoracic pressure. So it's measuring
Yep.
how hard you're working to breathe. This
Yep.
specific measure is the gold standard for UARS. That was not on my regular sleep study. Although if
Yep.
someone's looking with a very keen eye on the sleep study data, they can see increased effort to breathe when the waveform changes shape. Like there are
Correct.
things they can do to notice this, but
Yep.
it's usually just a
Yep.
computer scoring these things. Nobody is
Yeah.
looking at every detail. It's just too much.
Yeah.
But I flew to this lab where they used the PES monitor, and what they found was that I was working hard to breathe and my brain was arousing every 2 minutes. Those weren't spontaneous arousals. Those brain arousals correlated with every time I worked harder to breathe, my brain would wake up.
Yep.
And there's also a couple different scoring criteria that different labs use. And I think it's important for people to understand this because so many women, so many people are getting missed and misdiagnosed, even though they're getting sleep studies. So the
Yep.
American Academy of Sleep Medicine, and I believe it was 2012, updated some guidelines and said the recommended rule for scoring these sleep studies, Rule 1A, is that there does
Yeah.
not need to be a drop in oxygen. There could be a 3% drop, but there does not need to be a drop. We can count an event as an event if there's a brain arousal correlated with that effort to breathe, but you don't have to have your oxygen drop. And my oxygen never really dropped. I was in the high 90s the whole time.
Well,
And most labs are using Rule 1B. It's the Medicare guideline where you have to
yeah.
have a 4% oxygen drop for the lab to count that as an event. So
Yeah.
anybody with upper airway resistance syndrome is going to get missed. Those events will not be counted because their oxygen is not dropping 4% below their baseline a certain number of
Yeah.
times. So this is why a lot of people leave their sleep study either confused, upset, or maybe happy like I was, because they're like, I don't have sleep apnea. I really just have depression and anxiety, and I've got emotional issues. And that's where the confusion and the big problem is.
The whole reason that you had a normal sleep study is because your brain was waking you up enough that you kept breathing okay, enough that you didn't hit the mark.
So
And
is that's a question. If a woman or a person's brain, a child or an adult who's not dropping in oxygen, if the brain wasn't so amazing, it wasn't so sharp and quick,
yeah.
and they wouldn't wake up, then the oxygen would drop. Then you would become
Well,
apneic, probably.
and again, this is where it can start to show up. So we know, for example, alcohol is fuel on the fire to having airway and breathing problems, because partly it deadens the brain. So your brain reaction is blunted. Plus, it's a muscle relaxant, which then makes the muscles around the throat relax. So for some people, this can actually be part of their dynamic. But this is the irony. If you look at your sleep study form, it says do not consume alcohol on the night of your study, or maybe have a glass of wine or two at most. Now, if that individual's real life is that they drink considerably more, then we're not measuring that person's real life. So we have all these things that can interplay and affect it all. But again, if we look at women again, when we look at sleep studies, let's forget about when they're menopausal, just normal cycles. Okay, through their normal cycle, their sleep study results will change depending on which stage of the cycle we measure them in. And how often do we measure people in general? Once. We take a snapshot, even though we've known for 20 years that a single night is not representative of your sleeping experience. The reality is we need to do 4 nights in a row. That's actually what the science shows. But then we end up having a huge resource problem. It's hard enough getting a sleep study in the first place, but imagine then if every person getting a sleep study was getting it for 4 nights in a row.
You were talking about how one night in a sleep lab or a take-home sleep study is not capturing real sleep. Even in the recommendation would be 4 nights, but nobody does that. We can't do that. Insurance would never cover that. We don't have manpower for that. And also, when you're hooked up to electrodes all over, that's not your normal sleep anyways. So the take-home message to me is that, yes, sleep studies are important. They could be very diagnostic, but we should not always rely on the sleep study data when there are signs and symptoms.
Yeah.
That physician needs to do a thorough investigation of all the symptoms that person's having, plus
Exactly.
looking at the cranial facial structure, the nose, the palate, the teeth, the jaws, the tongue position, all those play a role. So it's just so many people are getting missed because that whole big picture is not being investigated. So I'm wondering, can you talk about some red flags that clinicians should not ignore? What are some red flags in an airway focused evaluation? So some things I'm thinking of, and then you can add to this because I have a little list I put together. And one of the things that happened to me that was probably very much a sign was waking up with my heart pounding, like in the middle of the night, all of a sudden heart pounding.
Yeah.
Also nightmares, or dreaming you can't breathe, dreaming you're drowning. I mean, that is like a telltale sign, right? You're not breathing and your brain is having a dream about that. Daytime fatigue, and fatigue is different than sleepiness. So just feeling wiped out. Brain fog. I did not know I had brain fog until I was put on a CPAP, which I wore religiously for 2 years. The first night where I was able to wear it and tolerate it and felt fine, I woke up and I'm telling you, my head was clear and I never knew that was what brain fog was before, and that was a clear brain. I didn't know that.
Yeah.
Pain in the jaw, TMJ pain, or muscle tension in the face from clenching or grinding the teeth, or waking up with tightness or morning headaches, cold hands or feet, Anxiety at night or during the day,
Yep.
difficulty falling asleep or
Yep.
waking up in the middle of the night, so different types of insomnia. What else do you
Yep.
want to add to that, Dr. McIntosh, that are red flags so clinicians or patients could think about?
I think we need to focus on the patients, because the reality is that this is not through any direct fault of their own. The clinicians are behind the curve on this. And this is why women get missed, because women come in with the list of things that you've mentioned. Now, if they hit someone like me, I'm going to be like, here we go. You're just ticking boxes left, right, and center. But not everyone is me, and not everyone is the other people that you are familiar with and collaborate with. And it's only really, again, you look at your own situation. Unfortunately, you had the problem, but fortunately, you are in a place where you can tap into pretty much everyone in the world through the network of experts throughout the world and get the answers that you needed, because you're in that privileged position of being able to do so. And that's not everybody. And that's where it sort of spirals, is because if you didn't know me, if you didn't know Bill, if you didn't know Jerry, and so on, you still would be this struggling and so forth, and medicated and brain fogged and starting to just find life difficult. And it should, that's not, it's great for you as an individual, but that's not what it should be for everyone else, in terms of the opposite, which is just getting missed. So I think the list that you shared is really good and important. I would throw a few other things into the mix. And this is, all of these things are suggestive. They're not absolutes, but these are sort of clues. And we take these pieces and we start putting the jigsaw puzzle together. So let's work through it. So things that are obvious to me, don't miss the obvious in the list. If you're snoring or mouth breathing, that's the obvious stuff on the list. That you don't even need to go past those two things to be flagged. If you notice that you get hay fever, you just got flagged. If you have a history of nasal trauma, you just got flagged. If you notice that the nose gets blocked on one side and then you have to reposition, and in repositioning the other side starts to get blocked, and you're sort of going back and forth to work around that. So your nose is only blocked on one side at a time, but it takes turns. You just got flagged. I think if you have a history through your childhood development of needing braces, particularly if you had dental extractions as part of that, you just got flagged. If you have a problem with heartburn, reflux, indigestion, you just got flagged. And the reason for those flags that I'm waving is because they all interrelate with the fact that there are either direct or indirect relationships to how your airway is working and functioning. And again, we don't need to go into the weeds there. This is all just about having these touch points. So there's flags that you can wave in terms of a checklist. If you have fibromyalgia, you just got flagged. If you have chronic fatigue, you just got flagged. And we're not saying that
PTSD, you
breathing,
just got
yeah,
flagged, right? If you have
yeah, yeah,
PTSD.
exactly. Yeah. We're not saying that breathing airway is the be all and end all and it's the only thing and it's the only solution. But geez, it's a big one, and it's a big one that's missed.
What about
You know,
atrial fibrillation? If you have AFib,
yep,
that's a huge.
yep. All these cardiac arrhythmias. AFib is the most common when it comes to obstructive sleep apnea. The cardiologists pushed back on that for a very, very long time. I remember going through it when it started to get flagged, and the cardiology profession pushed back on it and pushed back on it. And now it's standard that they'll send people off for sleep studies to screen
Reflux,
for it.
another
Reflux,
thing
yeah,
that would just be like, you just got flagged if you have
yeah,
reflux.
yeah, yeah. High
Because
blood pressure.
when
The reality is that by the time we're finished, we've actually mentioned everything.
everybody's
That's
flagged, basically.
that's the general reality. But in terms of the points of dismissal, I think that's a pretty good list in terms of what, and most people have more than one. It's not this just like, oh, I've got just that one. It's just, oh yeah, I've got a couple of these things, and I didn't realize they could all be related, and I didn't realize that I can actually be better.
Yeah. Well, what should patients do if a patient's suspicious of this sleep disordered breathing, upper airway resistance syndrome? They get the sleep study, it comes back normal. The doctor says they're fine. What's the next step? What should the patient do if they don't feel that that's hitting the target for them?
So, look, part of all of this is realizing that a sleep study is not the be all and end all. Okay. And we also got to be cautious of terminology. Okay. So we talked about mild sleep apnea. So we break sleep apnea into mild, moderate, severe. Now, the natural response to hearing mild sleep apnea is to thinking, oh, it's not that bad. That's the natural human brain response. Okay. Oh, you've got mild sleep apnea. Okay. What people don't realize is that sleep apnea is the bad end of the spectrum. So mild sleep apnea is the mild end of something that is really bad. So again, it's kind of like getting a UFC fighter hitting me with what they would consider to be a mild punch. Now, a mild punch in a professional fighter's hands is not a mild punch in someone else's hands. Their ability to hit someone is at the severe end of the spectrum of physical force. And if they hit you gently, they don't want to really hurt you, but they want to let you know just how much they could hit you by. They let you know that enough that you can feel it, but they hold back in terms of what they could have delivered. Someone like me is going to go, oh, man, that was really bad. And he goes, I wasn't even trying. And it's the same thing. Mild sleep apnea is not a mild disease. It's the mild part of badness. It's the beginning of something that's really, really bad. We don't have a term called mild cancer.
I'm gonna say.
Because nobody in their right mind is going to go, oh, it's okay, I've got mild cancer, I don't need to worry about it. But
So
we say,
big
I've got
picture
mild
is we
sleep
don't
apnea.
ignore mild. We don't ignore mild. So let's say the results come back mild or everything's fine. Self-advocacy wise, what should women do when they're told everything's normal, and how do they advocate for themselves without being labeled
Look,
as like anxious or difficult?
I think that realistically, the sleep study is only part of the process of
Yeah.
assessment. It's part of it. I think as a minimum, okay, as an absolute minimum, in terms of what should be on the checklist in no particular order, is seeing an ENT, is having their dental skeletal configuration assessed, is
But
having
this needs to be an ENT that understands airway and
oh yeah,
sleep,
it's got to be
because there's many
look,
patients
I have pushed back and resisted the term, but I just have to
give up.
I just have to give up. Because the reality is it's just a revolving circle of disappointment when they say, I've seen the ENT and they said I'm okay. It's like, well,
Exactly.
what sort of ENT were they? Oh, well, they mostly specialize in, and it's like, well, at the end of the day, you need to see an airway ENT. And I think we just got to draw that line in the sand now and just say, look, if you're going to do this, you need to see an airway ENT. Someone that knows enough about this that can actually be more useful to you when it's not straightforward. When it's straightforward, I have a blocked nose, I broke it when I was 16. Any ENT that deals with that can deal with that. But when it gets into the I'm struggling to get my answers, that's when you need to go to the next level. So I don't want to suggest that every single person needs to see an airway ENT, because that'd be ridiculous. But when you sort of go, something's not right and it's not adding up and I'm just not sure, that's kind of when you need to get that extra layer to it all. So I say an ENT, assessment of your dental skeletal form, and then, what you do in terms of the myofunctional bit. How are all these things then integrating, representing and functioning? Are there signs and so forth that, someone like yourself, through your skills, experience, training, learning, and self-own story, can actually be more attuned to?
Right.
So whether
I
that's,
agree when you said the dental skeletal. So that would be a dentist or orthodontist
yep,
that is into dental sleep medicine, or like an airway dentist or orthodontist. That's not a separate
yep,
profession, but somebody who has
yep,
understanding and training in that area. Because if you go to
absolutely.
a practitioner that doesn't, they're going to not see what you're
Yeah,
concerned about. And the oral
yeah,
facial myofunctional therapist, I think
yeah,
a lot of us who are either speech pathologists, dental hygienists, a lot of us really understand this airway component. You
yeah,
might want to do
exactly.
research just to make sure it's not somebody new and they don't really understand all these
Yeah,
details. But oftentimes the oral facial myofunctional therapist serves kind of like a quarterback or a guide for the team, where they can help refer you to
absolutely.
these other specialists. So if you feel like you have this problem, you have a sleep breathing problem, but your results come back like you're fine, but you just don't feel right, set up your team, find these
Exactly.
people like Dr. McIntosh just said, and continue to seek out answers. Because when you sense something's not right, usually something's not right. And I feel like that's really good to help with self-advocacy for patients, is what you just explained, what we went through. I want to touch on a couple other things really quickly because I know we're running late for time. What would you say treatments are? Because I'm sure people are listening. They're like, well, how do we even fix this or cure this? So
Yeah.
what would you kind of sum up some treatments?
The treatments need to be tailored to the problem at the end of the day. Okay. So from that perspective, I sit in my ENT world. I don't jump too many fences. So, and let's just keep it simple. If the nose is not working properly, that needs to be changed. Now, if it's structural, it's surgical. If it's allergies, it's allergy management. You've got to deal with those underlying factors. The hormonal things, well, look, that's where if you're starting to have those problems and you're wondering about HRT, talk to your specialist that manages HRT, and then be your own guide as to how much that HRT does or doesn't help what your nose is doing, so that you can sort of then work out, all right, I'm going to have to get the surgery done, and so forth. When the problem in adults, it doesn't matter if you're male or female, the problem with all these dental skeletal problems is we really want to define you before you turn 12 years old. If you ever wanted to talk about a preventative strategy when it comes to jaw growth and development, getting you before the age of 12 is actually one we want to get you. But that's obviously not when you're showing up. You're showing up and you're in your 40s. So from the treatment point of view, it really depends a lot on what it is. We can do things to grow and develop jaws now. We can resort to using mouth guards or splints that hold the jaw forwards at night to compensate for the lack of lower jaw growth by bringing that jaw forwards, which opens up the airway.
And that's something a dental sleep medicine doctor, a dentist
Yep.
who specializes in sleep
Yeah.
medicine might do an oral, they call oral appliance or mandibular advancement device, can be very effective. Orthodontists can do, like you were saying, it's hard to move jaws or growth, but there's certain techniques, perhaps Marky, where
and then now we can basically put in surgically assisted processes and so forth, all the way to full-on extensive jaw surgery to reconfigure the jaws. That's the extreme of it all. And then the myofunctional therapy part of it, you've got to get your reflux under control. You've got to look at your lifestyle. Smoking is bad for you. Alcohol. This is a remarkable statistic that's actually coming out of the US at the moment, Nicole. The consumption of alcohol has plummeted in the US. It's the first time in a long time where there's been a downward trend in alcohol consumption. I think the message is getting out there that ultimately there is no safe dose of alcohol. We have a social construct and so forth to it all, but you can have too much of a good thing, but there's a suggestion it's not even a good thing. But I'm not here to promote teetotaling, but at the same time, if you're having problems with your breathing and your sleep and you are drinking substantial amounts of alcohol in the evening, well, look, that's a lifestyle factor that you need to look at and control for.
So there's other treatments or things that can help are lifestyle changes, also environmental factors, elevating the head of the bed, things like that. And also CPAP. CPAP is also a viable alternative, although it's not easily tolerated for many people, including sensitive women, but that can help as well. I want to do a lightning round for you of just 2 questions because I know you're really good at spontaneous answers. Okay, 2 questions, then we'll finish. What is one sentence every fatigued woman needs to hear?
The problem is real. The solution may be difficult.
Ooh, that was really good. The problem is real. The solution may be difficult. That hits home. That is so true, but there are solutions. So keep fighting, women. Keep investigating. Last question. What is one thing every clinician should stop saying to women?
Can I do this as dot points? Dot point 1.
However you want. It doesn't have to be one sentence.
Yeah, it's just your hormones. Every woman gets this. You're doing too much. I mean, they're the ones that's where it gets fobbed off the most.
Yeah. Take an SSRI. You're just depressed. It's because you have kids and you're just tired from your kid. Yeah. Okay. This is great. So we're going to wrap up because you've spent so much time. This has been so informative. I really hope this episode helped so many women. I feel like it will. I feel like it opens doors when you understand more and this problem is real. The solutions aren't easy, but there is help out there. And if you are a female that has children, young children, just know early intervention for these issues can prevent future problems. So I want to just talk about your book as we wrap up. I'm just going to read the back cover. And then I didn't do your bio in the beginning. I'm just going to read your bio just so people understand who I'm talking to right now, because some people might not know who you are and they need to know who these words of wisdom are coming from. So in terms of your book, Female 40, Fatigued and Forgotten, this is the back of your book. You are the author of Snored to Death. ENT specialist Dr. David McIntosh shares his knowledge on one of the most neglected parts of women's health, their sleep. Are you tired of being tired and tired of not being heard? You eat well, exercise, and try to look after yourself, yet no matter what you do, the fatigue never lifts. The doctors say your tests are normal. You're told that stress hormones are just part of getting older, but deep down you know something isn't right. In Female 40, Fatigued and Forgotten, ENT specialist Dr. David McIntosh reveals the hidden physiological reason why so many women feel exhausted, foggy, and dismissed in midlife. He explains how sleep-disordered breathing, airway collapse, and oxygen imbalance silently drain energy and disrupt hormones, often years before a diagnosis. With compassion and clarity, Dr. McIntosh gives women the science, strategies, and self-advocacy tools they need to finally be taken seriously. This book is your guide to reclaiming vitality, restoring confidence, and rediscovering yourself, because you're not just tired. You've been overlooked, and it's time to change that. Wow, that's so powerful, Dr. McIntosh. Let me just go over your bio, and then we'll do a little wrap up. Okay, so who are we speaking to? Like, who is this amazing person? Dr. McIntosh is a highly respected ENT, ear, nose, and throat specialist based in Australia with internationally recognized expertise in airway obstruction, sleep-disordered breathing, and pediatric ENT care. Dr. McIntosh has dedicated his career to understanding the complex relationship between airway health, facial and dental development, and overall wellness, especially when airway issues are subtle and often overlooked in standard clinical practice. Dr. McIntosh holds a PhD for research into healing after sinus surgery and has published extensively in peer-reviewed ENT journals. He has presented on ENT and airway topics throughout Australia and around the world, and is a fellow of the Royal Australasian College of Surgeons and a consultant specialist to the Australasian Academy of Dental Sleep Medicine. With clinical practices in Queensland and beyond, including Sunshine Coast, Brisbane, Sydney, and Melbourne, Dr. McIntosh is a sought-after clinician for both children and adults facing these complex airway challenges. And one wonderful thing about you is you work collaboratively with dental, orthodontic, sleep medicine, and myofunctional therapy professionals to improve diagnosis and outcomes for patients with snoring, upper airway resistance syndrome, and obstructive sleep apnea. And you've written so far 5 books. You've written Female 40, Fatigued and Forgotten. We talked about that. Snored to Death, The ABC of ENT, ASD, ADHD, Sleep Disordered Breathing, A Parent's Guide, and also A Parent's Guide to ENT. So I just thank you, Dr. McIntosh, so much for all your devotion and dedication to the field and to helping patients from children through adults. You really help provide solid answers and insight that can really change so many people's lives. And I thank you also for mentoring me when I've had questions, helping professionals and helping patients alike. So thank you so much for all of your time. We really, really appreciate it.
Nicole, it's my pleasure. And thank you so much for everything you do, because I love learning from everyone else that you learn from too, and sharing it with all of us.
We can never know too much, right?
Exactly.
All right, Dr. McIntosh, have a great rest of your day. Thank you again. Take care.
Take care. Bye.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much, and join us for the next one.